what you see is not what is. And what I mean by that is what you see on the X-ray does not always represent what you're seeing, what is going on. And what I mean by that is there's something called parallax. Parallax is, so if I look at the camera here and I say, you know, this finger is at my eye, right? Well, you know it's not. So if you've got a needle tip coming down here and it should be in my eye, from the one view you have, you would think that's in my eye until the camera moves around and you would say, gosh, it's not at all in my eye. Now, if the finger is on my eye from every angle, you know, then you would say it's on my eye. And that's why when we're saying the sacroiliac joint or others, we'll set it tilt a little bit so we can see to make sure that even though our needle looks over the joint from that projection, you come from a different angle. If there's a lot of space, you're not there. So there's something called parallax. The concept of parallax is that the image is not, these rays of light, or X-ray, are not coming out perfectly parallel. They come out at an angle. And so what will happen is that if you are, let's take a picture with just mag 0. Okay. Okay, so let's save that picture and swap. You see that on the screen? Okay. Now, what we're going to do is swivel north just a little bit. It'll be hard to show this exactly because we're pretty close to the anatomy. And put this right in the center here, just a little more. Okay, that's good. Okay, that's excellent. Now the pen hasn't moved, right? But look here. What you see is, and take one more picture of Michelle. The pen tip is, see this line, this bar? It's at the bottom of the bar here, and it's at the top of the bar here. Now, it's not very accentuated because the needle tip is really close to that whatever electronic part is. But if the needle's farther away and we're on the outside, so let's say we're working here and the C-arm is not over that part of the anatomy, we're not in the right spot. And we may think we're in the right spot, but the needle is not, because the needle is actually there. But we think it's at the bottom, you see, just because it's not in the middle of the screen. So when you're working, we want your area of interest in the needle tip to really be in the middle of the screen. So try, when you're doing the procedure, to adjust the C-arm ever so slightly, just that you're following what's going on so that you know that the doctor knows and he's working on good information. Because let's say, oh, we'll just inject here, but you know, actually, we would have injected here, thinking we were at the bottom of that bar. You see what I'm saying? That's called parallax. And it's just the factor that these beams are coming out at a cone, not parallel to each other, and that's what causes that. So the other concept is that you generally want to be parallel to the skin. With our anatomy, when you're looking at the shape of the spine, you can see there's a curve, okay? And that curve represents, you know, what we call lumbar lordosis, thoracic kyphosis, bending forward, and then cervical lordosis, usually again. And that curve allows us to get to different projections. But it's important because when we want to see certain things in certain projections, we have to approximate that curve. So, say for example, if you wanted to go to the interlaminar space here, which is the space between these two bones, if you had a big angle like this, you can see the flashlight projection, you would not have a great view of that space. But if you were looking right down and you sent the X-ray beam through, you'd see a big open wide space. And conversely, if you were up like this, you might even see it better. Okay, so that's why this thing called orbital travel angle matters so much. And when you're in the cervical spine, you move certain ways. When you're in the thoracic spine, you move certain ways. And in the lumbar spine, and generally speaking, if you keep this thing, this image intensifier, parallel to the skin, so like if you're doing a sacral procedure, you come down, and Michelle, do you mind just showing us? You would have the image intensifier like that. And if you just, the simple, easy way to think about it is just look at the skin of the patient. Because the skin of the patient follows the contour of the spine. And if they've got a big booty, then you've got going to want to have more angle, okay? And so if you look, say, for example, at the sacral foramen, you may even want to really project down because you want to be able to see through those holes. But again, look at the patient. If they got no butt, you can honestly sometimes be just flat, and you're going to be fine. So, as we go, as a rule, the L4 is basically up-down. L5 will be a little caudocephalad, L3 a little more cephalocaudate, L2 a little more cephalocaudate, L1 maybe a little more, and then we start flattening out again. You see, and then we start going up to the thoracic spine. But sometimes, say in the high thoracic, you may say, I think I'm up-down, but it starts getting kyphotic, and you're again looking at the skin, they've got the hunch. Try and make this match the angle of their skin. It may be like this, so this would be like that most of the time, unless the doctor's asking for a specific odd angle. But that's the quick and dirty way to do it. Let's see here. There's something called density averaging. Density averaging is particularly important in imaging the sacroiliac joint of this joint, and you can see how it comes in a little bit like that. If you look at it, you want to angle the C-arm so that you're looking where it looks like you're looking down a canyon, okay? And you can see, but the problem is that it's like looking at the edge of a piece of cardboard, okay? If you were to imagine looking through a piece of a cardboard like shipping material you got from Amazon, and you look like this, if it's off a little bit like that, it will still look like you're looking down it on X-ray. If you're like this, it won't look like you're looking down it. But then when it comes like this, the projection of the walls of the canyon become very sharp. But we're only concerned with the mouth of the canyon. And this canyon has got curvy walls. So it can be really challenging for you guys to image the canyon correctly because you're looking at the whole canyon, because you can look through the entire canyon all at the same time with the X-ray. But really, all the doctor's interested is the opening of the canyon, because that's where it's going to put the needle. So it's really challenging sometimes. Because of that, and we'll get into this in a little bit, when we start, we generally start medial to the joint and then just walk a little lateral, hoping to find this spot, this little step off where the needle just slips right into the joint, and then we inject and see it go. But that's the idea of averaging. Let's see. Scotty dog. So Scotty dog is an interesting thing. Let's just see if we can take the Scotty dog to this. The Scotty dog is just a projection, and it's an oblique projection of the C-arm. And we'll take it'll be hard with this one a little bit. Okay, so the Scotty dog view is essentially this view, which is on the C-arm, and we'll show you later. It's an oblique view. And we're looking at the lumbar spine just to show you some of the anatomy. What we're looking at is, you can see the vertebral body right here. That's what we're looking at. You guys know that that's, this part right here. So that's this part right here. Okay. And then we can see the facet joint, okay, right there. And then we see something called the pedicle. And the pedicle is this guy. And we can see this view looks like a Scotty dog in a way. And what we mean by that is, if you were to imagine that this is the ear of the dog, here's his big eye, here's his snout, okay, here's his little throat and chin right in here, and then coming down, here's his foot, okay, and then coming right down there, and then the foot comes up like that. Here's the back of his ear, he's erect, and there's the back of his back and neck. And so if you come down here, here's another Scotty dog. Here's his head, here's his ear. Now this guy has a little fracture right in there, probably underneath. And that's what they're showing you, is that they have a lysis. This is a spondylolysis, is what we're seeing, which is where there's a fracture. And you'll see this on imaging. We'll point it out to you, where the bone slips forward. But this is the concept. With this view, you're able to do many things, because superimposed on this view is the nerve root. And you can't see a nerve on X-ray. You can only see bone on X-ray. So the nerve is coming out like this. And if you put your needle right under the chin of the Scotty dog, then there's this little triangle that we call the safe triangle, and there's a question about that. But if we inject our contrast, you will often see the contrast run up right along the actual nerve root. There's another way to go. So now you can also see that this Scotty dog allows you to see the disc. We call this on plane. So the disc is on plane, and we can also put a needle right here and inject into the disc, do a discogram, do a retrodiscal type epidural. We can also block the facet joint. The nerve sits right here, right here. But this view is a very useful view. So when the doc says Scotty view, you need to go oblique enough until you start to see this view. Basically, this thing moves in 3 axes. You know, it goes this way, in and out, and then lateral. So generally, we call this the AP view, and it's AP. And what AP means is anterior. This is where the beam is coming from, to posterior. And if you just remember, all of the terms mean where the beam is coming from to where it's going. All of them will make sense. So there's something called, anterior posterior, which generally is from the belly to the back. If it's the opposite, let's say the patient's lying on their back, it would be PA, from the posterior back part of the patient to the anterior. C-arm didn't move, of course. But when we say we want an AP shot, it means we want up-down, essentially. If we wanted to go a little angle like this, okay, and this angle is called the orbital travel angle of the C-arm. This would be cephalo, which means head, caudad, which means tail. So, and those are 2 big words, but always just think about the first one. Cephalo, whichever one we say first, means it's coming more from the head and it's going more towards the tail. Cephalo, caudad, and the opposite is where you have caudocephalad. And so this angle, you say, well, I want a little more caudocephalad. Shall we go more like that? A little more cephalocaudad. Should go like that. Let's go to AP. Should go right like that. Now, I'd say, give me a little more oblique to you. Should move like that. Or oblique to me. Okay, a little more oblique. And you can see a little more oblique, a little more caudocephalad. And she'll know immediately. Caudocephalad is from the tail to the head. And these are the views and this would be a great Scotty dog view for, say, the L5S1. Because you got the angle, you got the booty right here, right? And we're looking down at that L5, and then we're getting a little oblique to get the Scotty dog. And if you just follow it, it's hard to put all those terms in, but if you just repeat those terms, caudocephalad, cephalocaudad, oblique to me, oblique to you, you're going to get a lot. The other last ones are basically pistoning. Okay, and the C-arm has that piece of metal. It basically pistons towards Michelle, or away from me, or towards me and away from Michelle. Those get most of it. And the only other view that we really use quite a bit is a lateral. And we've already seen that. And that just means go across and bring the whole C-arm around. And she can do that. Now, what's interesting is when you think about the disc, we're often trying to look at the disc, like a discogram, etc. We want to keep, so the disc, say of the L5S1, if you think about it, here's the L5S1, like that. You can see it's angled, like that. I was thinking of it like a frisbee. And if you make the C-arm in the same angle as the frisbee, you're going to be fine. Because you will approximate, and even the lateral. You don't have to go and change the angle to get a lateral. Because when you want to go back to where you were looking, say, just the previous angle where it was just a caudocephalad with an oblique angle, you don't even have to do anything. You just come back and you just keep that angle. And you can see that disc is now, the frisbee hasn't moved, the C-arm hasn't moved, and everything's still in plane. We often will say cross table angle. Give me a cross table, it's the same as lateral. Coning just means collimation. We'll talk more about collimation here in a second. AP. There's something called Mag 1 and Mag 2 on the C-arm. So, normal view. Magnify 1, it requires a little more energy. Mag 1. And then Mag 2 even a little more. But it's blowing it up and allows even more precise placement of the needle. And if your eyesight is not perfect, then it'll blow it up and you can see even better. So when you're magging, even more reason to collimate more. Now there's 2 ways to collimate. There's a bar collimation, which we will sometimes use in the thoracic spine, for example, because the x-ray is going through a ton of air in the lungs out here, air and lungs, and so it'll say, well, there's so little tissue, I don't have to put as much energy through, and it will underexpose the spine. So if you close the bars on either side, and I hardly ever do it because we're working such a small, but you can bring these let me just show on it's that button right there, but it just brings in a bar on either side here of the actual x-ray source. The one we almost use all the time is the circle collimation. The circle collimation, which is the opposite, or a different one than this, allows us to simply cone down this image so that when we're working close, and let's say you're using your hand or holding it with an instrument, it really protects your hands from the x-ray. Those are the two types of collimation. And we always collimate to the maximum all the time. I want Michelle to collimate more than I'm almost comfortable with. We've been working with each other long enough, she just knows. But you'll never be faulted for collimating too much. If the doctor has to ask to open up, fine. You're always protecting